I want to introduce, first of all, Dr. Orhan Akman, a assistant professor at the Columbia University and a longtime member of our scientific advisory board. Orhan, are you
yes.
on site there? Great.
Right. And thank you for your introduction, and thank you for all you attending, and thank you, Deborah, for describing how you feel, and these are very important for us to target in our research. Now, today I am going to talk about the biochemistry of APBD and how disease starts, and what is the biochemical background of it, and how we can use it as a marker for any kind of treatment that we may have in the future. As we all know, the disease is caused by mainly the decrease in the glycogen branching enzyme activity. And what happens when the branching enzyme activity decreases because of mutations mostly we encounter. So the glycogen is a molecule is made up of glucose that we consume or it get into our body by the carbohydrates we consume in our meal. To be able to be used by the cells during the times that we don't eat or not full anymore, the glucose first is being stored and used during this in-between meals. And the glycogen has a very special structure. It has been synthesized by two enzymes, the glycogen synthase with the help of branching enzyme. So if the branching enzyme is deficient, here you can see on the left-hand side, the branches are going to be a lot rare compared to the normal glycogen, and it becomes a very rigid molecule like starch, which is found in plants. And its digestion is very ineffective, and it accumulates over the time in our tissues. So its accumulation is being monitored or can be proven by histological sections. Here you see the nerve sections that shows the accumulation of polyglucosan. So those accumulations doesn't happen right away, and it happens over time. And it looks like it starts affecting the individual like around 40 or 50 years of age, and it gets worse after that. So how do we measure the branching enzyme activity, and how it affects the progress of the disease? So this is little biochemical, it's a little bit detailed information, but the enzyme assay that we do, and we use it mostly to diagnose the patients with glycogenesis type 4, is an indirect assay. So in this assay, we basically use the two enzymes, actually one enzyme, and with the other molecules, we make it work reverse. And with the branching enzyme that comes from the sample, that enzyme builds the glycogen, and we measure the activity of the enzyme by using the secondary enzymes activity. So there is no direct assay. That's why it is difficult, and it changes from tissue to tissue. So, and with the effect of the branching enzyme, the real enzyme that we put, which builds the signal, has the opportunity to increase the signal significantly. So this assay has some pitfalls. As I said, since it is the combination of two enzymes, but also it has been highly affected by the glycogen that comes in the tissue. If there is too much glycogen, it gives a false negative. Or if there is no glycogen at all, then we get also negative signal, which means actually that maybe patient doesn't have APBD. But this doesn't mean that they do not, because if there is no starting glycogen to start with, measurement is going to be impossible in this setting. So in order to avoid those problems, when we get the sample, of course, the sample comes with the glycogen and branching enzyme. And we divide it into two and then kill the branching enzyme in the other reaction. And then we just add our enzyme, the glycogen phosphorylase, which works reverse in this case and synthesize the glycogen, and are labeled glucose. And then, of course, if the glycogen affects our reaction, in the spoiled sample, we don't expect any branching enzyme activity, so we subtract this from the result of this, and then we get the result. Now, before, people used to, or the doctors used to send only the muscle samples or the liver samples to measure the glycogen branching enzyme activity. But after I started in Dr. DeMaro's lab, we noticed that, we already did know that the branching enzyme is ubiquitously expressed in all tissues. So there is no reason to go for muscle or liver specifically, although those organs are the main organs that stores the most glucose in form of glycogen. I started measuring the enzyme activity in the peripheral blood lymphocytes, and actually I got a lot better result because peripheral blood lymphocytes do not have the glycogen, and it has very low background, and we really measure very efficiently the real enzyme activity. And so this is important because having a biopsy of liver or muscle biopsy is not easy, and yet drawing a blood and sending to the lab is a lot easier for doctors and for patients. So this is one aspect that can be easily used in any clinical setting to measure the enzyme activity or any kind of treatment that targets to improve enzyme activity. Now, enzyme activity presents in all tissues, and so we get the tissue samples from patients, and of course we have the mouse model that we measure for the enzyme activity in the tissues, and also we did in the past test the embryonic tissues for the enzyme activity. And so we measured pretty much the same amount of enzyme activity except liver and muscle, which are higher, not only because they store a lot of glucose in terms of glycogen, but they also design to synthesize those enzymes a lot more than the other tissue. But so we tested all those samples, and we noticed that pretty much every tissue has the same amount of enzyme activity. And of course, if there is any mutation, it decreases according to the mutation that happens. Now, of course, checking the enzyme activity from the embryo until the adult showed us that enzyme activity stays same from birth to 50 or 60 years of age. So it doesn't change. And it doesn't change by the severity of the disease. And although disease occurs after 40 or 50 years of age, enzyme activity is still the same, it doesn't change. So, I would like to emphasize this because I got this question quite a lot in the past. The patients were actually trying to target the enzyme activity, thinking that because enzyme activity decreases over time. It does not. Over the time, what happens is the polyglucosan accumulation increases, and at the end, that is the main reason that patients have the symptoms. So, if we target the enzyme activity, of course, in the genetic setting, you cannot change it. But there are two options that we can actually affect the enzyme activity. One is the gene therapy. So we can simply replace or put a correct gene into the cells and make the gene produce the branching enzyme and increase the enzyme activity. And in the second option is, we have found this in the almost 30% of the APBD patients, a specific mutation in the intron that prevents the synthesis of the normal message to synthesize the protein. And this message can easily be interrupted by antisense oligonucleotides. So these two treatments are expected to increase the enzyme activity. So I'm not going to stay on gene therapy because this project is already being taken by Dr. Oh Dong-san in Duke University and Dr. George Minassian in the UT Texas, and I'm sure they are advancing very well in that field. Now, I concentrated on the intronic mouse model and improving the transcription from the intronic allele. Now, what I did originally, so as I said, we did the enzyme assay in blood, and I have treated the mice with the antisense oligonucleotides that will improve the transcription. And I obtained the blood from the animals and separate the white blood cells and did the enzyme assay. So this graph shows the sample that I have tested. This activity belongs to heterozygous, compound heterozygous mice treated with the antisense oligonucleotide. And this one shows the control. And so as you see, treatment with the antisense oligonucleotide in 2 months actually increased the enzyme activity. And we have other, of course, mouse model is just a tool. Our main purpose is to make sure that this enzyme activity is increased in human cells. And we design everything based on the human mutation. And we knocked in the human mutation into the mouse. And now we have the human fibroblast cell lines that we can also test the antisense oligonucleotide. And as you see on this graph, just similar to the mouse model that I treated, in this case, I treat the patient fibroblast with the antisense oligonucleotide. And it significantly increased the enzyme activity compared to the untreated controls and the treated with the antisense oligonucleotides, which doesn't really target the area that we want. So, and this enzyme increase, I don't show the control here, but it is more than the double of this activity. Curve is going further up. But this much of enzyme activity generates actually the condition as the heterozygous individuals has. And as we know, heterozygous individuals do not progress the disease, or they do not manifest. So if we can use this antisense oligonucleotides, we have the option, or we have chance to improve the symptoms. All right, and thank you. I hope I didn't exceed my time. I would like to thank APBD Research Foundation for getting me started in this project and bring me to this point at my career. And also, I'm thankful for the donation from the Robert Fram and the Guy Lipsy. Thank you.